Welcome. This is Dr. Phil Rosori. I'm the medical director of Village HopeCore International, and this is the beginning of a series of 20-minute presentations on the core concepts of global health. This will be part one. There will be an introduction before, but to start with part one, what we're going to try to do here is to review the most important core concepts in global health and then relate them to our program in Africa. So the introduction will talk about the program in Africa, but basically Village HopeCore International for 18 years has run a health and development program in Africa that has focused on a Grameen-style village bank, which has been extremely successful, and a healthcare program focusing on mothers and children. At this time, we service over 100,000 women and children living in 516 villages on the slopes of Mount Kenya. And during these presentations, we will talk about the history of that. It's been extremely successful. We won some major international grant awards, so this program has been peer-reviewed, and we will go into that as we move forward. This set of presentations is targeted for our global health fellows and Kenyan nurses in the field to give a background of the theory of why HopeCore does what it does in Kenya. So I have been the major architect of the healthcare portion of this program for 18 years. I was there in the beginning. You will see that history a little bit later on. And so before I did this, I'd already been doing global health for over 25 years. I taught for 17 years the global health travel medicine portion of the family practice residency at the University of California, San Francisco School of Medicine. And now for over 20 years, I have been consulting and teaching, traveling internationally in global health. For the initial 23 years of my career, I actually did clinical medicine and ICU medicine in Northern California. So I come out of both a global health background, which actually started for me before I went into medical school, and then a clinical background after medical school, and now a return in the last 20 years to global health. So let's move on and begin to talk about this. The first thing I want to focus on is that global health is very much a numbers game, and numbers are extremely important to us because it allows us then to track populations, to predict what's going to happen to those populations so that we know how we can provide efficient services to those populations. But what can be forgotten in the numbers game of global health is that for every number, there is a real individuals behind those numbers. That is women, children, men who are affected by some of these disease processes and the poverty that we're going to look at. This is a young girl from the Kenya-Tanzania border. She lived a very difficult, uncomfortable life. She was born low birth rate, low birth weight. She was malnourished as a child. She had chronic anemia secondary to her malnutrition and to chronic malaria. She had multiple bouts of infectious diarrhea. She had episodes of pneumonitis and other infectious diseases. And this child did not survive. And she is basically the symbol of what we want to prevent and who we want to help in our program in Kenya. And you will see her picture again because it's a way of bringing us back to the right brain realization of what's going on. So I do lecture at Stanford University, and this actual series is taken out of a series of presentations that I have done at Stanford and another one that I will do in another 2 months. It's also taken out of a 10-hour core global health course that I do for physicians and nurses interested in global health. And so it's extremely important to realize that there is a right brain connection or to create in yourself a right brain connection between the numbers and real individuals in the field. Since we work in Africa, we deal with these individuals all the time. And so the reality, the right brain reality or intuitive brain reality of what we're doing is very obvious. But when you go and lecture, for instance, as I will in 2 months at Stanford Medical School, for those individuals, this kind of poverty, these kind of diseases are very far removed. And so it does behoove us to focus on the fact that there are real people behind these numbers. Now, global health, by definition, is a huge field. It's global. And therefore, we really have to define what part of global health are we working on. And I want to be very specific that Village HopeCore International's program in Kenya is focused on the 2.5 billion critically poor people on the planet. Now, that is a technical definition. It's not the definition of poor that you would use in normal conversation. These people aren't poor of character values. They're not poor for spiritual values. They are poor on economic indicators that are critical to their health and development. And those people then have inadequate access to basic sanitation, to shelter, to basic nutrition, and to health care. If you look at the planet's population as a whole right now, there's about 7.5 billion people on our planet. And for those people who know about these kind of things, you can get fairly good agreement that about a third, or 2.5 billion, of those people are critically poor. Now, poverty is an interesting definition that I've followed for years. It will always be relative. It's also interesting the people who define poverty and define the poor of the world are always the rich people. The poor people are never have any input into this. I think that the issue here with the number of people truly poor on the planet is twofold. One, we don't know exactly. My guess is it's definitely higher than 2.5 billion poor people, but I will take 2.5 billion poor people as 2.5 billion poor people as the number because you can get good agreement there. But I would like to point out that there is at least 0.5 billion, if not 1 billion people who are at risk for falling back into the 2.5 billion poor people. And we saw this in 2008 with the economic downturn as people in India and China lost their jobs and fell back below the poverty level. We see it in Kenya, in our area, when we have these droughts that move through the area and people will lose maybe one crop and be without a significant income and food for 6 months, and then another crop may fail. And these have usually occur in the area where we are, below the Sahara Desert, below the Sahel, at patterns every 6 to 8 years or every 10 years we see these droughts. And during that time, millions of people then who were above the poverty line will not have the food to feed themselves or to sell and will fall back in to the critically poor of the world. This is an extremely important number. And it does contrast with the rich of the world, and I think we do have to talk about that, because the 2.5 billion poor people have the same amount of assets of about the 100 richest people in the world. So 100 of the richest people in the world could easily stand in the room that I'm creating this video in, and they would have the same amount of resources as all the people in China and India if they were all the poor people of the world. So that's a massive group of people, and it shows an incredibly imbalanced planet, and that gap is actually widening. And there is evidence out there that in the next 30 or 40 years, 25 to 30 of the richest people in the world will have the same amount of resources, the 2.5 billion. So this does create political instability. It is a very unequal planet. The other thing I want to focus on is that we will talk a lot about the difference between global health care and global healthcare delivery in the 20th century versus the 21st century. And I have been one of the people that have tried to focus a lot of attention, particularly in my lectures at universities like Stanford, on the differences between healthcare, global healthcare now in the 21st century versus what we did in the 20th century. That is, learning from our mistakes of the 20th century and moving on into more effective and efficient delivery systems for healthcare in the 21st century. One thing to realize is that we do a rural population health and development program in Kenya, but people kind of misunderstand that when they look at us, thinking, well, this is a rural healthcare program. How does it relate to urban populations? And what you have to understand here is that everything that we do on the slopes of Mount Kenya in 516 rural villages can be done in urban areas, and more importantly, it can be done much cheaper in urban areas. Because if you look at our budget, you will find that one of the great costs for us is getting our people to 200 schools, 516 villages, over unpaved, slick, steep roads where we need to have four-wheel drive vehicles, which are expensive to maintain and have poor gas mileage, but it's the only way that we can get them to these particular places. If we were doing this in Nairobi, for instance, we could send our people by local municipal transportation, and it would be much cheaper to run our programs in the schools, as you're going to see, and in the neighborhoods if we were working in a rural, in an urban area. So keep that in mind. This is not just a rural program, but could be actually more efficiently done for urban populations. The high urban population or unemployment that we've seen coming out of the 20th century that we're going to look at in a second certainly has really aggravated this whole issue of social unrest in many countries. And we've seen this now in the last few years all across Northern Africa, which was the driving force between the revolutions that have gone on there and the current conflicts that are going on there. In places like Kenya, unemployment can be 40% in the 20 to 45 age group. In areas like Zambia, it can be as high as 80%. So these are very significant issues of one of the effects of this exponential population growth that we're going to look at that greatly occurred in the 20th century. And the political instability, obviously, of these problems is very significant for us doing healthcare work, and also for the relationship between, if you wish, the developed world with the less developed world, and how something like what's going on in Syria can destabilize a whole area like Western Europe. Let's take a look at world population, and let's just hit a piece of it from 1950 to 2000. As I think everybody knows, the exponential growth of population began really around the beginning of the industrial age that occurred right before the 1800 and was fueled by the exploitation basically of steam power created by burning wood, and that created transportation and manufacturing, and that exploitation then of energy really began to drive an explosion of population, which really caught fire post-World War II. So if you look at what happened post-World War II, in 1950, basically at a few years after World War II, the total population was 2.5 billion, and it would rise in the year 2000 to 6.1 billion, and 2018 then is going to be around 7.5 billion, or 3 times what it was post-World War II in 1950. The composition, though, and where that population is extremely important, just as important as the total population number. And what you see here is this white bar is the population of the more developed countries of the world. And as you can see, it's grown, but it has not grown greatly. But what's obvious here is how the black line has increased. Massive population drift into the developing world because of unequal population growth rates. And this means that the size of the problems that we're dealing with in the developing world are huge, and we're going to have to be extremely effective, both what we do economically for this 2.5 billion critically poor people in the world, and also what we do with healthcare. And there's definitely been drops in the total number of poor people on the planet over the last 20, 25 years. Starting with decreasing poor populations in India and China as they became the manufacturing areas of the world, the data processing areas of the world, and poor people could find jobs and could move their families above the poverty line. But even though there's been population, there's no reason to not realize the severity of our problem, because as you can see here, that the current total population of critically poor people on the planet, 2.5 billion people, is equivalent to the total population of the planet in 1950, which was 2.5 billion people. So these are huge population issues that we're going to have to deal with, and that are going to get worse as we move through the 21st century. And basically what this shows is this is the trajectory and population legacy of the 21st century. And we are now going to have to deal with the results and problems that that creates in the 21st century. So that is a trajectory then that we have to be careful of and will follow. Now this is a very important chart, because this then takes a large population and breaks it down into its composition, and is incredibly important for planning healthcare and development programs in the future. And one of the great problems in the 20th century, and sadly into the 21st century, is the short timelines that these development programs, both economic development program, health development programs, have. And one of the reasons we won a major international grant award of $100,000 is because we had a long timeline. When we're going to really look at what's going to happen in Kenya in mid-century, at 2050, and how we need to plan for that now. And we're going to go into that in detail. But let's just take a look at the population of Kenya and realize that this is the same population pyramid that you would see in Peru, that you would see in Afghanistan, that you would see in Nepal. This is basically the population pyramid of a country who has seen reduction in early childhood mortality, reduction in mortality without reduction in birth rate. And so what we begin to see then over these last 25 or 30 years is that the widening base of the population, which are all individuals under reproductive age, then creates a very interesting and important problem for the future. So what this is, these are cohort pyramids. Over here you have males, and then you have females. These are the percentages of the total population, and then you have the 0 to 10, 10 to 20, 20 to 30 age group, and you see how they move up the pyramid as these people become older. And as you can see, in a place like Kenya, you have a small amount, a relatively small amount of older people, but a huge amount of under people. And most of these countries have 50% of the population or more below reproductive age. So what's going to happen here as we go out to 2050 is this column is going to become massively large at the bottom, these broad-based pyramids. And that means that we're going to be able to predict very closely what the population will be like in 2050 in Kenya, and what the composition of that population will be. How many women, children, men, etc. And in our case, the focus is how many mothers and how many children and how many school children. And that is extremely important. So I want to end this segment of looking at Kenya in 1987. When I first arrived in Kenya, the first time I went to these villages on the slopes of Mount Kenya was 1987. There were 18 million people in Kenya in 1987. In 2017, when I was just there are now 44 million people in Kenya. So more than doubling in that period of 30 years. The importance here is that by 2050, that population will probably double again, and that we're going to be looking at somewhere between 80 and 90 million people in Kenya. So that is really something we should then think about, take a moment to assess, because that's going to change what we do for the people we serve and how we serve them in this area of Kenya. And our program at HopeCore was built largely around the fact that we understand this runaway population that we're seeing in the developing world, and particularly in Kenya. And the new statistics show that by 2050, 39% of all the children in the world will be on the continent of Africa, the continent that has the least resources to deal with those children. So the time to plan for 2050 is now. That should be our time horizon, not 2045, when we all of a sudden see, oh my God, we have all these children here and all these mothers. What are we going to do to avert catastrophe? So this has been about 20 minutes. Let us stop at this point and pause, and then we will return and pick this up on part 2.